Hello, my friends. It's Jill Osborne from the Interstitial Cystitis Network. It is Sunday, February 1st of 2026, and it is time for another live IC support group meeting. Now, let me just get my workspace all set up here. Something really interesting to talk about today. All right. Get a little drink. This is a support group meeting for anybody with interstitial cystitis, bladder pain syndrome, hypersensitive bladder syndrome, ketamine cystitis, chemocystitis, overactive bladder, and even chronic prostatitis. My goal in doing these meetings is to help you be strong, knowledgeable, informed. I want you to be able to have really, really good discussions with your doctors. I want you to be able to take charge of your treatments. I want you to feel hope. I want you to feel comfort. I want you to feel encouragement because, hello, my friends, it is a new year. We are stepping away from the disappointments of 2025. We are moving into 2026 with a new outlet, new energy, a new determination to find the cause of our pelvic pain, find the cause of our IC, so that we are not suffering anymore. Because here's the thing. You suffer. How can I even say this? You know, if you've been up all night, unable to sleep for a week, much less a year, much less 10 years. If you are struggling and afraid to eat because you know that when you eat something, you might suffer terrible pain. If you are afraid to have sex because you know it's going to be painful and it's going to trigger a flare, a significant flare. If your pain levels are so severe that you can barely walk. If you are dealing with people who are telling you that it's all in your head. If you are dealing with people who are telling you that there's no hope. You're not alone. This is common. But there is hope. And I am going to present the most amazing case study today, which I think will give hope to anybody out there suffering from multiple conditions and not understanding why. So right now we are live streaming. We are live streaming on Facebook. We are live streaming on YouTube. So when I'm looking this way, I'm looking at Facebook. When I'm looking this way, I'm looking at YouTube. Normally when I do these meetings, I usually do a little bit of a 30-minute intro, and then I'm happy to take any questions that you might have. Nothing is off the table. You feel free. I challenge you to embarrass me. I am happy to take any question that you might have. And I really should introduce myself. So I am Jill Osborne. I am the founder of the Interstitial Cystitis Network. I am the longest serving IC support group leader in the world right now. 33 years and counting. This will be my 33rd year. I am a nerd. What that means is I've got 3 college degrees. I've got degrees in chemistry. I've got degrees in pharmacology, drug development. I've got a master's degree in psychology. And my website, the IC Network, was my doctoral dissertation proposal on how to deliver support to patients who were homebound. And the irony is that we in our first year, we were honored with the National Cancer Institute as an outstanding health website. I never could finish my PhD because I was in too much pain. But 30 years later, I'm very proud that that little student project is still here, alive and kicking, and still helping a lot of people, because in the end, that's what we got to do. You know what? When we're long gone, people are not going to remember the car that we drove. They're not going to remember the money that we had unless we're jerks. We're going to be remembered by the actions that we take and the help that we provide and the love that we give and the support that we offer. And that's really my intention when I do these meetings. So hello, Anne. Thank you. You know, I was looking at this today. Look at this. You see the difference between this part and this part? That is not deliberate, my friend. The lighter hair came in after my breast cancer surgery, and I didn't even have to have chemo. So anyway, I'm rocking interesting hair right now. Anne says, my friend has vaginal pain. What can that be? It can be a lot of different things. It can be bacterial vaginosis. Could be a candida infection. It could be pelvic floor dysfunction. I mean, there are lots of different things that can cause vaginal pain. Hello, Gay. Nice to see you. Hello, Jennifer. Nice to see you too. Okay, so I've been really busy. I've been working every day. In fact, I just put up a new video on our YouTube channel. We did the formal launch of our book, the new IC 101 Diet Guide. I've got a big newsletter that's going to go out to about 34,000 patients. If you want to get our free newsletter, just go on over to the IC Network, icnetwork.org. And you can sign up for it there. A pop-up window should come up, or you can go under news in the news section, and there's a link for it. We also have a magazine. We're finishing up our magazine right now for winter. That should be done this week. That's called the IC Optimist. So lots and lots and lots of different things are happening. So in the process of doing this, I came across the most fascinating case study. And I think you guys are going to just be shocked by this. So as a support group leader, I mean, there are patients that are really easy and there are patients that are really complex. There are patients who just have one little symptom, and there are patients who it's like their whole body is messed up. And when you're a patient who has many, many different conditions, it's so confusing and it's so scary and it's so frustrating. You just want to be normal. And yet you've got migraines, you run into the bathroom all the time, sex is painful, yada, yada, yada. It's like, what the heck is going on? And then worse, somebody says, okay, well, let's just put you on medicine for the migraines. Let's just put you on medicine for your IC. Let's just put you on a lot of medicine. And the thing is, okay, you're on a lot of medicine. Maybe your symptoms are a little bit controlled, but the problem is you're still messed up. That hasn't fixed anything. And in the end, every single one of us is an anatomical mystery to be solved, right? You are indeed a mystery. And this is one reason why online support groups are so challenging right now, is you can't put apples, oranges, and bananas in the same group and expect success. Everyone has slightly different, interesting cases. So what happened to Julie might not happen to Mark, et cetera, et cetera. So here is a truly fascinating case study, and I think you're going to find this amazing. A 42-year-old woman was referred to an outpatient clinic for her pelvic pain. Her neurologist was treating her for migraine headaches, had noticed that she was having a lot of chronic pelvic pain. She suffered from a multitude of other conditions, including gynecologic issues, neurologic issues, stomach issues, musculoskeletal issues, heart issues, endocrine issues, hematologic issues, and in fact, she was showing signs of psychiatric distress. She was being treated. So for gynecology, she was being treated for chronic vulvodynia and pain with intimacy. Okay, for neurologically, she had a terrible history of daily agonizing chronic migraines, as well as occasional seizures. And she had been seen at the ER multiple times for her migraine. She had to get intravenous therapy. She needed pain medicine, and her neurologist noted that she had worsening confusion, and it was getting very, very difficult for this patient to concentrate. The physician ordered neuropsychiatric testing, and while her intelligence test showed that she was superior, her short-term memory was poor, and she was unable to focus, and she had been diagnosed with ADHD, okay, or ADD. Okay. She was completely disabled. She had to drop out of college, drop out of graduate school, and she was unable to drive because she had severe disorientation, and she was on many, many medications for her migraines, etc. Okay. For her gut, she had a long history of constipation and bloating with a diagnosis of irritable bowel. And a precipitous decline in her health status was marked by a spontaneous colon perforation 8 years earlier. And ever since then, she had had 13 abdominal surgeries, including a total colectomy. However, her surgeons noted that she did not heal well. Musculoskeletal issue. She was treated for back pain. She had a curve in her spine. She had had several spine surgeries for this, as well as a spontaneous cerebral spinal fluid leak. Yikes, that's like big deal. From her heart, she had frequent episodes of tachycardia and fainting. And from a psychological standpoint, she had treatment for anxiety and depression. But everything else appeared normal, right? She had normal kidney function, and she had seen more than 50 doctors. In fact, she had contacts for 60 doctors in her phone. Okay, I'm just going to read this. At consultation, she was noted to be a poor historian, and she demonstrated confusion and distraction. She reported daily migraine headaches, difficulty concentrating, as well as non-cyclic pelvic pain associated with an upright posture for 8 years. She reported vulvodynia, pain with intimacy. A physical examination showed a tall, muscular woman who was anxious and confused. She often trailed off in her speech. She did not complete her sentences. And she also had Ehlers-Danlos syndrome. She had generalized joint hypermobility. An external pelvic exam showed exquisite vulvar tenderness and scattered vulvar varicose veins. Okay. That latter finding is really important. She had scattered varicose veins that were visible on her vulva. So what does that mean? That means that we're having issues with blood supply. There's a blood supply problem. So the doctors did an MRI. No, they did an MRI. And what they found was a really significant case of pelvic congestion syndrome, that her left iliac vein in her pelvis was severely compressed and limiting blood supply. Okay. So, blood supply is everything. We've got to have good blood supply to support the tissue, to get good oxygenation with the tissues, to get good nutrition with the tissues. We know that tight pelvic floor muscles cause ischemia. Ischemia is basically poor blood supply because veins are being squeezed by tight muscles. But there is another condition called pelvic congestion syndrome where veins get compressed and or sometimes dilated. The blood flow is just compromised. So under moderate sedation, they confirmed left iliac vein stenosis of greater than 50%. And she was initially treated with a stent in the vein. She was prescribed one medicine for 30 days. She wore high compression hose to get the blood flow out of her legs, and she was advised to drink 100 ounces of electrolytes drinks a day. At 1 month post that procedure, her confusion and her dizziness was gone, but she still showed a little bit of cognitive dysfunction. At 6 months, now again, once it restored blood flow in her pelvis, her quote unquote mental issues basically went away. At 6 months, she reported improvement in cognition to a point where she was able to go back to graduate school and she was able to resume driving. According to her neurologist, she had fewer headaches, her fatigue was reduced, a little bit of dizziness continued, but they did a little bit of medicine which helped fix that. Her pain with intimacy persisted, though. That was an issue. So then they did, her symptoms were definitely way better, but then they kind of baselined and they started going back down again. And they did another exam and they found the same problem with blood supply in another vein. So they stented that second vein. And her pain with intimacy, let's see here, hold on a sec. I'm going to get this right. Let's see. They had to inject her vaginal wall to reduce the pain with intimacy, which resolved after 3 months. Neuropsychiatric testing showed her memory at the 95th percentile. Her IQ increased after treatment for pelvic congestion syndrome. However, at 18 months, her dizziness returned and a little bit of pain with intimacy returned. Ultrasound suggested a developing right iliac vein stenosis. They did a CT, they found it, they treated it, and guess what? 30 months post-treatment, she has no pain with intimacy, no vaginal pain. Her migraine headaches are basically gone. They're down to 4 per month instead of every day. She's had no fainting episodes. She was able to complete graduate school. She started her own business. Most of the medication she was on before this, she was now off. Upon examination, she appeared more alert. Her speech was spontaneous. She completed sentences. She had no vulvar tenderness, or vulvar varicose veins. She was scheduled for an annual clinic and imaging follow-up. I want you to think about this for a moment. So here's a woman who's running to the bathroom. She's got chronic pelvic pain. She's got vulvodynia, and now she's showing very, very clear signs of a cognitive dysfunction, poor memory, short-term memory, not able to complete sentences. Now, it would be perfectly fair for us to assume that at least some of those doctors she saw suggested that it was all in her head. Because, hello, she was confused. She was confused. Certainly, she had depression, anxiety. Certainly, this was all in her head. And yet, guess what? It wasn't at all in her head. All of her symptoms, from her migraines to her pain with intimacy to her vulvodynia to her running to the bathroom, were caused by a now newly recognized condition called pelvic congestion syndrome, of which they now believe that 30% of IC patients have. Was it 30% of IC patients or 30% of women? Hold on a sec. I might have that wrong. I am writing an article on this right now. You know what? Let me go to my article because I had that quoted in my article. Where did I put it? The point that I'm trying to make here is that we cannot accept anyone suggesting that we caused our symptoms or that we need mental care or that this is our fault. Her case is really, and one of the things they talk about very, very clearly is the fact, and I want to say this. The patient case illustrates how pelvic venous obstruction or insufficiency may be related to sometimes disabling syndromes of unknown cause. Specifically, POTS and resulting orthostatic hypotension can be disabling. What that means is when you sit up, your heart starts to race and you faint. That's posterior orthostatic tachycardia syndrome. I think that's what that stands for. In this patient, we proposed it responded to addressing impaired venous blood supply to the heart, venous blood return to the heart with resulting diminished cerebral blood flow. Physiologic studies have shown that patients subjected to orthostatic stress had decreased cardiac filling pressure. The female patient showed statistically significant drops in stroke volume and systolic blood pressure and increased heart rate. Oh, it really makes me think. Anyway, there's more and more. So we proposed that her cognitive symptoms had at least some basis in decreased cerebral perfusion as a result of her pelvic congestion syndrome. Patients with chronic fatigue, POTS, and fibromyalgia experience decreased blood flow to the brain and therefore is vascularly linked. In addition, these patients often report the symptom of brain fog. Brain fog has been ill-defined in the past, but is often described by patients as cloudiness of thought patterns, impaired memory, difficult thinking, focusing, or difficulty communicating. These descriptors are altogether different from brain fog reports from patients with general fatigue, anxiety, or depression. Cognitive function has been shown to decline following orthostatic stress in adults with chronic fatigue, yada, 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 yada. In this study, a complex patient was presented for the treatment of chronic pelvic pain using stents and sclerosis of the abnormal veins. The patient's pelvic pain was relieved, as were disabling migraine, syncope, and brain fog. Originally diagnosed as ADD, the patient's disability status was removed, while other factors such as reduced pain, including reduced migraine headache frequency, reduced need for pain meds, improved sleep, and overall diminished need for medication. The potential relevance of compromised cardiac venous return in the setting of chronic venous disease is discussed in this report. While a physiologic explanation was submitted for this patient's improvement, yeah, okay, I know that's way too. When I read this study on Friday, it made me think of the hundreds of patients that have called me over the years presenting with all of those symptoms, who were unable to find any relief from bladder therapies, who were unable to find doctors willing to work with them, who showed very clear signs of confusion. And yet at the same time, one of the symptoms that patients describe with pelvic congestion syndrome is you feel like you're carrying a bowling ball around in your pelvis, a heaviness in your pelvis. I can't even count the number of patients who called back especially in the early days, complaining of, oh my God, I feel like I'm carrying a bowling ball around in my pelvis. It hurts so bad. We know what that is now. That's pelvic congestion syndrome. So I don't want anybody out there to give up here. This is about us all learning together. And more importantly, when we see things like this, a very good study that I know that there are going to be some people who listen to this support group meeting in the next month or so who are going to go, oh my God, that's me. And the goal here is, if you feel a heaviness in your pelvis, if you are having all of these other kind of random symptoms like migraines and vulvodynia and pain with intimacy, but most importantly, you have got this heaviness in your pelvis that gets worse as the day goes on, man, it is time to go have a to talk to your doctor about pelvic congestion syndrome and get that ruled out. Because look at this patient who I'm sure assumed that she was going to spend the rest of her life in her bed is now cured. She was able to go back to grad school. She was able to start a business, and all of her symptoms are gone because this entire time she had been misdiagnosed. Well, maybe not misdiagnosed. They just didn't go a step further to understand her more complex case. And the single deciding factor was a doctor who looked at her vulva and said, wow, you got varicose veins. We better explore that a little bit more. Maybe you got varicose veins deeper inside your belly too. And maybe you got varicose veins at the iliac vein, which then goes right up to the brain, which can affect cognition. John said, is pelvic congestion syndrome diagnosed with an MRI? It's diagnosed with a magnetic, hold on, I can give you the exact name. Here, hold on. Magnetic resonance venography, which revealed a greater than 50% diameter compression of her left common iliac vein between the right common iliac artery and the lumbar vertebral body. You know, one of the problems that we have in Western medicine is doctors play in their sandbox, right? You go to a urologist, they're going to focus on the urinary tract. You go to a gynecologist, they're going to focus on the reproductive tract. And as Dr. Weiss said so elegantly in his book, Breaking Through Chronic Pelvic Pain, nothing operates in isolation in the pelvis. Everything influences everything. And for complex patients like us, we got to kind of step away from the bladder, especially if you've got a normal bladder on cystoscopy. And let's look at some of the other things that can influence bladder health, like muscles, like nerves, and like blood supply. And blood supply and blood circulation disorders is emerging as yet another vital area that has to be explored more. And I remember with the International Pelvic Pain Society, who I think do the best meetings, the most educational meetings on IC and chronic pelvic pain, they started bringing in a interventional radiologist, somebody who specialized in pelvic congestion syndrome or venous disorders, to add their insight into some of the more unusual causes of IC and pelvic pain and also contributing factors of IC and pelvic pain. Really, really fascinating stuff here. We have, for example, you know, I mean, what am I harping on constantly? Phenotyping. And now every medical organization in the world says, yes, you have to phenotype. You know, we were saying that 7 years ago, my friend. This is an example of patients, our voice, contributing to the cause and truly mattering. And so last year, there was this really big international conference of IC experts, 60 IC experts who came to Wake Forest University for what we call a global consensus meeting on IC. And they basically picked 10 areas to focus on, one of which was phenotyping and yada, yada, yada. And their phenotyping, they believe that there are 4 phenotypes. They believe that there's bladder wall-driven Hunner's lesions. That's one distinct group. We all understand that. That's a no-brainer. They believe that there's a second phenotype, bladder wall-driven small bladder capacity, reduced bladder capacity. Now, and the problem with that phenotype is that it doesn't help doctors look for unusual things. Like, okay, what about the estrogen atrophy patient? What about the chemocystitis patient? So I don't really like that phenotype very much. I think it's way too broad and it doesn't help clinically. They believe that there is a pelvic floor dysfunction phenotype, and they believe that there is a widespread pain phenotype. They call it a variable phenotype group, of which pelvic floor is part of. But case studies like this, pelvic congestion syndrome, we've got to get that into the mix. Because the flaw here is if you've got vulvar pain and you go to the doctor and they go, well, let's just give you some yeast meds, even if you don't have yeast. And if that persists for months and months and years and years and years, maybe, just maybe, we need to look at that. Maybe there's something else that could be causing some of your symptoms. So anyway, I don't think that I'm summarizing this case study as well as I could. I just find myself absolutely fascinated that we have a typical IC patient with migraines showing cognitive decline and memory issues, and it was all linked to a problem with blood flow in her pelvis. And when they fixed the blood flow in her pelvis, all of her symptoms went away, pretty much. It's fascinating to me. Absolutely fascinating. Hello, Gay. Nice to see you. Sarah says, I have IC endovulvodynia. My doctor just told me that a pudendal nerve block wouldn't help the vulvodynia at all. I'm very disappointed. Well, did he say why? Sarah, why would they say that? You know, a pudendal nerve block is essentially diagnostic. So the whole point is we're trying to understand why your vulva is burning to the degree that it is, why you're in so much pain from your vulva. It could be related to a skin disorder. It could be related to estrogen atrophy. It could be related to infection of some type like yeast. But if your symptoms are positional in nature, if you're fine when you stand, but when you sit down it hurts, or when you bend over it hurts, then that tells us that we're probably dealing with more of a nerve issue. If you're having pins and needles, areas of numbness, that too also points to a nerve issue. And so doing a nerve block is diagnostic, because if they can silence a nerve and turn all your pain off, then then now we know that all your pain is coming from that nerve. That'd be really interesting to know why he said that and what he thinks your vulvodynia is coming from. Now, in our new magazine, we have a new article on lichen sclerosis. So lichen sclerosis is an autoimmune disorder of the vulva, characterized by very, very thin skin, easy tearing, lots of itching, lots of pain, lots of discomfort. The skin in lichen sclerosis turns pale, kind of gray, even whitish. The typical treatment for that is okay, and what do they think it's coming from? Well, there's a lot of vagaries about what could be contributing to the development of this autoimmune condition of the vulva. Repeated chemical exposures, pad rash from menstrual pads, could be fabric softeners, could be soaps, anything at all like that that's constantly provoking that skin. There are a number of different things that they believe would contribute to the skin breaking down and reacting in such a fashion. I also believe that poor blood supply could be playing a role in that, because the skin turns so pale. The skin clearly doesn't have good blood supply. So I think every lichen sclerosis patient needs to go have a pelvic floor assessment. And in some journal articles I was reading, they were saying that too. But in the end, how are we going to treat lichen sclerosis? Well, basically the only treatment for it is going to be a steroid cream like clobetasol to try to calm that inflammatory process. And at the same time, we got to get rid of all the chemical exposures here. There's just way too many chemicals that are affecting critical parts of our body that aren't meant to be exposed to chemicals. Think about menstrual pads. especially the thin menstrual pads. You know, a thin menstrual pad, the way it soaks up fluid is it's got a layer of chemicals in there that soak up the blood. But what happens is as soon as it gets wet, it starts to gas off chemicals. And so gynecologists have frequently talked about something called pad rash, where basically, if you look at a woman's, nether region, you see a rash in the shape of a menstrual pad. John said, is pelvic congestion syndrome diagnosed with an MRI? It can be, but an interventional radiologist will do a sonogram also. Hello, Bonnie, my friend. John said, how does pelvic congestion syndrome prevent men? I don't know. I haven't gotten that far. I mean, if you, here, let me see if I can find it. Hold on. I would imagine that if you've had like an injury of some type, a hip issue of some type. Yeah. Here it is, pelvic congestion syndrome in men. Here we go. It's often linked to varicoceles or pelvic venous insufficiency, characterized by chronic pelvic pain, scrotal heaviness, visible varicose veins on the scrotum, often worsening with standing and straining. It is caused by venous reflux or blood pooling in the pelvic area, leading to aching pain, potential erectile dysfunction, and urinary issues. Treatment involves minimally invasive embolization of the malfunctioning veins, which has a very high success rate of treatment. So the symptoms again, a dull, draggy, achy sensation in the pelvis, lower abdomen, or lower back, swelling, pain, or visible enlarged varicose veins on the scrotum, usually on the left side. Sexual dysfunction, pain during or after ejaculation, and potential erectile dysfunction. Irritable bladder, frequency, urgency, constipation. Leg veins, sometimes associated with visible varicose veins on the legs or inner thighs. Interesting, my friend. Interesting. Okay, let me go to YouTube here for a moment. And Pamela, come back. Hold on. Jennifer said, regarding IC Hunters, I was rushed to the emergency room 15 days ago. I'm 58. Thought it was a kidney stones or prolapse. Ultrasound showed fibroids, I think. Extreme pain. You're on hydromorphone. Should I get a hysterectomy? I can't bend over. Jolting pain in the vagina. Bowel movements cause burning new pain. Sleeping on my side causes burning pain in the vagina. Almost unbearable. Daily hydromorphone. Waiting to see 5 specialists. Okay. Number one, Jennifer, I'm so sorry that you're in so much pain. I know you must be, as somebody who's been to the emergency room way too many times myself in the last 2 years, I understand the fear and the absolute frustration you have to be dealing with such high levels of pain and not being able to get answers to why that's happening. So this is where we have to get just really down into basic anatomy here. We have to understand what's driving that level of pain. So that pain could be coming from the skin. If we have a skin disorder, potentially, including the inner bladder lining, pain can come from muscles, pain can come from nerves, pain can come from ischemia, and sometimes you have referred pain. What makes your, so you say a couple of things here that are really, really important. And number one, there was no prolapse. Hallelujah. We're going to take that as a good. There were no kidney stones. Hallelujah. Great. But you have fibroids. So question number one is, are we dealing with a fibroid so large that it's pushing over your bladder, pushing over something else? I was working with a patient not long ago who had a very, very large fibroid pushing on her bladder and diagnosed with IC, doing lots of bladder therapies. None of the bladder therapies were working, and she just kind of forgot about the fibroid. And she called me, and we were just talking about it, just trying to figure out her phenotype. And at the after about 30 minutes of talking, she said, "Oh yeah, the gynecologist said I had a really large fibroid, and maybe we should treat that." And it's like, wait. Okay, that's a problem. If you've got a really large fibroid, we know that too can cause frequency, urgency, pressure, and or pain. And we also have research that shows is when you get rid of the fibroid, the urinary symptoms go away. So I think concept number one here is what's going on with the fibroids? How many do you have? How big they are they pushing on your bladder? But you also say, I can't bend over. You have jolting pain in your vagina, and your bowel movements are causing burning new pain. I can see a fibroid tumor if it was pushing, depending upon its location, and if it's sizable, I could see that fibroid tumor kind of bouncing up and down as you're going, standing up and sitting down, maybe pushing on something causing pain, maybe. I don't understand why a fibroid tumor would cause a bowel movement issue unless the fibroid tumor is on the backside of your uterus, which is possible. Fibroid tumors can be either in the uterine wall, or they can extend inside the uterus, or they can extend outside the uterus. Sleeping on your side causes burning pain in your vagina. So again, what is that fibroid tumor doing as you're sleeping on your side? But man, I just want to know what's going on with your pelvic floor too, because those are also symptoms of pudendal neuralgia. So I think you need to buckle down with your doctors and try to understand your anatomy a little bit more. So number one, what's going on with your Hunners? Are they active or not? Number two, what's going on with the fibroid? A Hunner's lesion wouldn't cause pain bending over. It wouldn't cause bowel pain. So that's not from your bladder wall. Your bladder wall doesn't do that. Something else is doing that. And so I want to know where the fibroid is, how big it is. I would want to know what the health of my muscles are. Am I showing any signs of a pelvic floor tension? The good news is you don't have a prolapse, so that's great. But if you could, prolapses often happen when you have muscles that are very weak. Well, you may have muscles that are very, very tight. So we need to see what's going on with your muscles. How old are you, Hunt? You're 58. You're not painful. Hunters are under control. You only have one. Okay. Is the pain associated with going to the bathroom, with urinating? I mean, so 15 days ago when you went to the ER, what do you think triggered that pain? I mean, you're asking if a hysterectomy would be useful. And my answer is, well, yeah, if you got a big old fibroid tumor in there, then that makes sense. Hysterectomy is not a super easy surgery. I've had one. It's a year-long recovery. You're not going to be able to lift anything for about a year, even a grocery bag. You're going to be under 5 pounds. But if you've got a fibroid tumor that's affecting other structures, that hysterectomy certainly would be the right therapy for that. Or they could resect it out, but most doctors wouldn't do that. Most doctors at your age would just say, let's just do a hysterectomy. I just don't understand why you have pain when you bend over and why bowel movements are causing pain. And that makes me think we're dealing with a muscle issue too. Okay, urination is painful and it's very smelly urine. Interesting. Very, very interesting. What tests have they done so far, hun? What tests have they done? All right, Pamela said, my doctor wants to do Botox in the bladder, talked about a TENS unit. Have IC bladder, vulvodynia, overactive bladder. My bladder was stretched and biopsy on my bladder. I'm not burning for the first time in 26 years, vaginal burning. Okay. So again, Pamela, you're describing symptoms. We have to try to understand what's causing those symptoms in the first place. So the good news here is that they've looked in your bladder. The question is, what did they see when they looked in your bladder? Was your bladder healthy or were there any problems in your bladder wall? I would also, given the fact that you've got vulvodynia, I would also want to know what's going on with your vulva. Are there any skin disorders with your vulva? Or do you have lichen sclerosis with your vulva? And I would want to know what's going on with your pelvic floor, if anything. Larissa here says, I have lichens on top of everything else. Yeah, my mom had lichens for 30 years and it was rough on her. And I will tell you, when it was flaring, she just sat in the bathtub for a couple hours a day. I mean, and she got so old, even up to her 90s, she wanted to sit in the bathtub, but we got to the point where we couldn't get her out of it because she was unable to help us lift her. So we had to stop letting her take baths to soothe her vulva, and that was hard. Pamela said, once a bladder is stretched, a biopsy home with a catheter, I was on fire for days. Broke out all over. Vulvar too. It's better now. You broke out all over. So it sounds like you had some sort of reaction, maybe to the betadine that they put on your skin, or maybe you had an allergic reaction to one of the medications they gave you. By the way, for those of you who know me, you know that I had breast cancer a year and a half ago and a double mastectomy. And my incisions have been an absolute nightmare for a year and a half. Very, very painful. There are times when it feels like I have barbed wire wrapped around the front of my chest. And I finally saw my surgeon, and she injected a steroid into my incisions to try to calm that down. Made it worse. She warned me it'd probably get worse before it got better. But man, we will rise above it. I was listening to a great sermon this morning about not getting lost in grief and getting lost in sadnesses related to your health, that we just have to rise up, not live in the pain, move beyond it, and start focusing on the things that we want and need to do. At least that's what I try to do. Nav said, my bladder was totally normal when I had a cystoscopy 2 weeks ago, but I still have lots of pain and urethral burning. Okay, so now that's fantastic news. Now, so we know we're dealing with a perfectly healthy bladder. Fantastic. So there's no sign of a bladder disease that they were able to see. There was no redness. There was no inflammation. So now what we need to do is we need to look beyond the bladder. Because in many cases, if not in most cases of IC, the bladder is being victimized by something else happening in the pelvis, usually very tight pelvic floor muscles. So your pelvic floor muscles sit along the base of your pelvis and they go up the side, and your pelvic floor muscles help to hold structures in place. But if you were an athlete, if you were a gymnast, if you ever fell and broke your tailbone, if you suffered any pelvic trauma or of any type, what happens is these muscles often suffer significant injuries, compression injuries, especially like if you fall on one hip, like all your weight's landing on a small portion of your anatomy. And then you get a bruise there. And that bruise is proof that that fall was significant and it was so strong that it broke the blood vessels. But nerves in the area sometimes also get involved, but more importantly, muscles get involved. And one of the things that we consistently see in IC patients is kind of a history of minor pelvic traumas over time that build up until eventually we're dealing with very, very, very tight pelvic floor muscles. So now to me, concept number one here is, have they done a pelvic floor assessment? Do we know what's going on with your muscles? But let me ask you this. So now you say you have a lot of urethral burning. So there are several things that we look for with urethral burning. The very first thing that is worth considering is just estrogen atrophy. So if you are of a certain age, if you are on any medications which suppress estrogen, if you are on birth control, if you are on Lupron for endo, or you're just in your late 30s, early 40s, or older than that, estrogen levels begin to drop. And as estrogen levels drop, the skin becomes drier. So think about your urethra and your bladder for a moment. They have one strong function, and that is to release toxic waste. Urine is body waste. Urine contains ammonia and urea and all sorts of irritating things. So how does the bladder defend itself from ammonia? How can the bladder possibly hold ammonia for 2 or 3 hours at a time and not get damaged? Well, it turns out the way the bladder defends itself is with a really thick coating of mucus. Your bladder is like your mouth. It's a hollow organ that's wet and slippery on the inside. And that wet and slippery gag layer is a barrier that pushes or blocks urine from reaching the cells and irritating the cells. All right. So if you're following me so far, mucous membranes, whether it be your mouth, your vulva, your vagina, your urethra, your bladder, are supposed to be wet and slippery. The problem is that mucus production is estrogen dependent. So when you're young and have a lot of estrogen, you have a lot of mucus. But if you're older, guess what? You don't have the estrogen anymore, which means you don't have as much mucus anymore. And the urethra is the canary in the coal mine when it comes to estrogen atrophy. It is often the first part of the urinary tract to start reacting when your estrogen levels drop to a point that the skin gets dry. And that indeed is what happened to me when I was like 51 or 52. It felt like there was a drop of urine stuck in my urethra that would not come out. And I'm telling you right now, my IC self-help skills are excellent. You know, I mean, obviously I'm a support group leader and I wrote the IC network. I threw everything I knew at this urethral pain. Nothing worked, and it just got worse. And finally, I threw myself on the mercy of my urologist, the wonderful Dr. Mark Klein, who is long retired. He puts me up on the table. Now imagine I'm laying there in the stirrups. He's looking at me down there. I'm watching him through my legs, and he goes, "Jill." And I like look at him and go, "What? What'd I do? And he goes, "Didn't you use the estrogen cream I prescribed for you last year?" And I very meekly said, "No." And he looked at me and it's like, "Why?" And I said, "Because in my brain, I'm 25 years old and I can't possibly have an age-related issue." And he laughed. I mean, that's genuinely, I still feel that way. And I'm not 65 and I still feel 25. And he said, "Jill, the urethra is a canary in the coal mine when it comes to estrogen atrophy. It is the first part of the urinary tract to start screaming in pain. I saw this happening last year, and that is why I prescribed you the estrogen cream. You need to start the estrogen cream." Now, interestingly, I then the next day had an appointment with my wonderful gynecologist at the time, also now retired, and I bounced it off him, and he had a look, and he went, "Yep, absolutely estrogen atrophy. You need to use the estrogen cream." And they had me rub a pea-sized drop of estrogen cream right into the entrance of my urethra, and within 10 days, the symptoms were gone. And if I forget to use my estrogen cream for 2 weeks, it's back. So I am very, very invested in protecting my urethra with my estrogen cream. And in fact, I don't use my estrogen cream in my vagina as often as I probably should. I'm focused entirely on my vulva and my urethra. Now said, I've been prescribed estrogen cream and you're using it. Okay. The next thing you've got to consider now is the fact that because you're dry, your skin just can't defend itself. And this is where you have got to step away from any chemicals which are touching you down there. For example, fabric softener. You can't use any fabric softener. You can't use anything that leaves a scent in your underwear. That is leaving a chemical in your underwear that is going to irritate your skin. If I put on a pair of underwear, washed and sheer tied, within 5 minutes, I will have discomfort down there. Legit, legit, legit. And I can remember I went to Diane, who helped me start the IC Network 30 years ago. And I stayed with her in New Jersey for a couple of days. And I needed to do laundry. She did my laundry and she washed my underwear. She washed everything in Tide and used a fabric softener. I'm like, oh my God. And she has since passed away. She's an angel looking over us. Diane, I think of you all the time. I legit do. I just loved her. She taught me that your heart matters over your academics. I don't know how else to say that. Anyway, I got this underwear and I didn't say anything to her, and I put it on and I got on a plane and I was dying on the plane. Just dying on the plane with such terrible vulvar symptoms. Yeah. Bubble baths, bath salts. Julia says, what's the best cream to use? Well, if you're dealing with estrogen atrophy, it's got to be an estradiol cream. Generally, it's the estrogen that helps the skin produce mucus. But, for some people, it's just not quite enough. And this is where this baby is becoming one of my best friends, Vulva Balm. Vulva Balm mimics normal mucus and it protects the skin. I am loving Vulva Balm. So Vulva Balm is a very light, organic avocado, sea buckthorn olive oil product. There it is. And it's a very, 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 very light oil. You can use this every day on your vulva. And the reason why it's important is that when you're dry down there, as you pee, the chemicals in your urine are going to irritate the skin. We call that a urine burn. If you got urine burn, if your urine feels really hot, like it's coming out of you, it's not genuinely hot. It's just estrogen atrophy of your vulva. Man, Vulva Balm is your friend. Just put that on before you pee. You can put it on once a day, twice a day. You can use it as much as you can, but you don't need to use a lot of it. I mean, once a day would be fine. And it's perfectly fine with the estrogen cream that you're going to do. So Vulva Balm is one of my best friends now, and you can get it right on the IC Network website in our shop under Feminine Hygiene. Also, we have the same company makes a vulva wash. I was working with a patient this week, extremely dry, like bone dry, agonizing skin pain. Every time she peed, she just gasped. The pain was so severe while her urine was coming out. And she just didn't understand that was really from dry skin. And so, she ordered this, and hopefully she'll have it next week. And I'm sure that will help. But one of the best things you can do it's just like legit get a perineal wash bottle and just as you pee or immediately after you're done peeing, just rinse yourself off with water first. Listen, toilet paper is not going to take all the chemicals of urine off of your skin. Water will. And that's why everybody who joins a membership, who becomes a member of the ICN, gets a free water bottle, a perineal water bottle. Let me see. Do I have one here? Yeah, here it is. It's going to look like this, right? So it has a little fountain top. You just fill it up with just room temp water. Don't do hot. Don't do cold. Although you can do slightly cold if you want. This is the best friend of anybody with vulvodynia, anybody with lycosclerosis, or anybody with estrogen atrophy. My friend, it's $3.99. For God's sake, make the investment. I remember, I had severe vulvodynia in my 20s, and I found a support group down in the southern part of my county at a local university, and I went to it, and it was filled with menopausal ladies, and I was like 22. Oh, they took me under their wing, and they taught me about the power of the perineal bottle. And I'm telling you right now, using a peri bottle every day, every time you pee, is so helpful for calming your skin down. It is my go-to. I have had dozens of these, and they're actually really hard to find. So we found the manufacturer, and that's why you can buy it on our website. Pamela says, I am dry, hurts to touch. With his gloves, hurts to sit and pee. He gave you 2 creams, triamcinolone on the outside, Premarin 2 days a week. So, and at the same time, you would want to use something like this. On the days that you're not using the estrogen cream, use this, and it will help protect that skin. But Pamela, listen, that peri bottle is vital for you. That's going to help also. Pamela says, all clear years, no fabric softener, no. Yeah, but you know what? Even some of the all clear fabric laundry detergents actually can be a little irritating. I used to use Arm & Hammer, and it started irritating me. And then I also was using Ivory Snow. Ivory Snow was perfect for years, and then they added something to it, and that became irritating. So the laundry detergent that I use is 7th generation free and clear. And I always rinse my whites twice. And, there's nothing more frustrating than washing all of your underwear. Like I do my laundry usually on Sunday or Monday, usually Monday. Okay. So you do all of it. And then the next day you go and you put on a pair of underwear, and darn it, you can tell within a minute or two, at least I can. I start getting the prickly feeling down there on my skin, just everywhere. And it's like, oh, I forgot to rinse it twice. And then you have to rewash all the underwear. That's, but that's not with the 7th generation. That was with the other ones that I was using. Laura Wright says, it's just estriol cream to use if a hysterectomy due to uterine cancer. Better than nothing, honey. I'm so sorry about the uterine cancer. They thought I had endometrial cancer when I had my hysterectomy. It turned out mine was precancer. So, what the research shows is that using the estrogen topical creams are not believed to increase your risk of cancer as when compared to oral estrogens. And that was the first question I asked my oncologist after I was diagnosed with breast cancer is, can I use my estrogen cream? And she said, yes. I will admit that I don't use as much of it. I probably cut it down by half instead, and it shows. You know, that's a really interesting thing about a female anatomy as we get older is as those estrogen levels drop, things change. And one of the things that happens is that your inner labia basically disappears. It gets resorbed. And then when you use your estrogen, it starts to come back. And so I can certainly tell because I have not used as much of my estrogen cream, because I'm sorry, cancer is traumatic and we're going to do any damn thing we can to not go down that road again. And so I am more modest with my estrogen cream use, even though they did tell me they believed that it was perfectly safe. It's a really good question for you to ask your doctor. Nav said, okay, yes, I will definitely stop using my softener and laundry detergent that could irritate my skin. Excellent. Definitely do that. She says, I do feel that my pelvic floor is very tight. I started physical therapy and I was doing better until this past Thursday. My bladder and urethra are on fire. So what happened on Thursday? I'm not sure if I should go ahead and get the hydrodistension, although my bladder was totally normal. My doctor said I should try it to see if it works for me. Now I don't know what to do. Well, a hydrodistension as a treatment is what I call a destructive therapy. It doesn't fix anything. The reason why you feel better after having a hydrodistension is because it temporarily breaks the nerves in your bladder wall. And because the nerves are broken, you don't have as much pain. You don't have as much frequency urgency. And that's why you feel better. I mean, once you get over the couple day post-op, that's why many patients feel better. But the problem is that the nerves always grow back. And sometimes more nerves grow back than you originally had in the first place. And that's a problem. So I don't believe that doing recurring hydrodistensions in any way advances your long-term health care and solving the problem. To me, we have to understand your underlying anatomy. We need to understand what your phenotype is, because your phenotype drives everything. And sometimes it's what I call the chicken versus the egg dilemma. Which comes first, the chicken or the egg? And for us, it's which comes first, the bladder or the pelvic floor? They're both involved, but one is normally driving the other. So, again, as Dr. Weiss said, nothing operates in isolation. Everything influences everything down in your pelvis. So for some patients, consider the patient going through chemotherapy or a patient who's in severe estrogen atrophy. So you're in severe estrogen atrophy, your bladder can't protect itself. God forbid you be drinking green tea or energy drinks or coffee or cranberry juice. The acid is going to horrifically irritate the bladder wall. The bladder is going to start screaming in pain, saying, help me, help me, help me. And your muscles are going to get tight to protect you from that pain. That's called the guarding response. So the cause was the bladder irritation. The secondary effect was the pelvic floor tension. And our therapeutic priority for that patient is to figure out what the heck is irritating their bladder, stop irritating their bladder, calm the bladder wall down, hoping that the muscles will relax and release. But that's the smaller group of patients. The far more common situation is patients whose symptoms begin after a trauma, falling on your tailbone, like for me. Or again, if you were an athlete, or if you were assaulted in some way. But typically what we see is falls over time. So I fell and broke my tailbone when I was 13, and that's the first year that I developed urinary symptoms, couldn't sit through class. Now, of course, I didn't tell the doctor that. Teachers complained, called my mom. My mom takes me to the doctor. Doctor goes, must be a bladder infection. Put me on a massive amount of antibiotics. Didn't help. Kept having to go to the bathroom in the middle of the class and pissing off those teachers. But then I was diagnosed with a urethral stricture. It felt like I was trying to pee through a needle. legit. It was hard to get urine going because my urethra was like this. You know, your urethra is about the size of your little finger for a woman. You know, and that's width and length. But unfortunately, you have pelvic floor muscles that wrap around the urethra. So if those pelvic floor muscles are tight, what are they going to do? Oh, they're going to squeeze that sucker. So what they did is they used to force my urethra open with the urethral dilation. Nobody ever said, oh, why is your urethra tight? They just forced it open. I spent decades thinking I had a bladder disease. I never had a bladder disease. Every time they looked in my bladder was perfectly normal. So I am in that group where, and the typical progression we see is, a patient has a muscle injury. They don't really know they have a muscle injury. Could have happened after having a baby. Lots of different things can cause it. Your first symptoms are frequency, urgency. You go to the doctor. Doctor goes, oh, must be an infection. They give you antibiotics. They don't work. You go back to the doctor. The doctor says, well, let's try long-term antibiotics. They don't work. Hi, Johanna. Then you go back to the doctor, and the doctor goes, oh, let's try some bladder meds. Ditropan, Detrol, maybe your overactive bladder meds. They don't work. Finally, you go back to the doctor a year, 2 years later, and the doctor says, I hate to break it to you. I think you've got this incurable bladder disease called interstitial cystitis. And you're like so thrilled. Okay, we know what it is. Thank you. I needed a diagnosis. The doctor hands you the diet. Doctor puts you on an antidepressant. Maybe, God forbid, they give you Elmeron. They send you on your way. And you do everything. You follow the diet. You do the meds for 6 months, a year, 2 years, 5 years, 10 years, 20 years. But you're not better. You're still flaring badly. Why? Why? Because guess what? The underlying problem really isn't your bladder. The underlying problem is that old muscle injury you had. And if that pelvic floor assessment finds tight pelvic floor muscles, the correct treatment is physical therapy. And the goal of physical therapy is what? To restore blood supply. We got to get the blood flowing again. So how do muscles directly influence the bladder? If your muscles are tight, they squeeze things. And they can squeeze the blood vessels so badly that your bladder is not getting enough blood supply to be healthy. So what healed me? Well, it wasn't a bladder installation. It wasn't one of many medications that I took. It wasn't urethral dilations. It wasn't nerve stimulation. What healed me was physical therapy. And that's still what I have to do. I still do physical therapy. All right. So Nav, if you want to give me a phone call this week, or even we can go into Zoom after this meeting. I'm always happy to go into Zoom if anybody wants to talk. And if you can let me ask you a bunch of questions, I might be able to kind of narrow down your phenotype a little bit and then send you back to your doctor with maybe a new set of questions. Because I think your questions are really legit. You don't really know what to do. So I think it'd be really interesting to talk with you a little bit further. So we can go into Zoom. If anybody wants to go into Zoom, I can set it up. Not a problem. Pamela said, toilet paper, you're trying. Okay, the best toilet paper. I'm telling you right now, the best toilet paper is bamboo toilet paper. Caboo is the brand I use. Paper, the paper product toilet paper is dusty. And I think it leaves a lot of particulate matter on your skin down there. That's probably not good. Once I switched to bamboo, and I did that during COVID because we were, having toilet paper mailed to us back when we could get toilet paper. Y'all remember that, don't you? Remember when all the toilet paper was gone the first year of COVID? We're like going, okay, what are we going to do now? Hey, my friends, a peri bottle. Just rinse yourself off, pat dry with a towel, and you're good to go. So bamboo toilet paper is what I recommend. Julia said, you're scared to have sex because orgasm can cause severe bladder cramps for days. Actually, what's happening, Julia, is that is a pelvic floor flare. So the bladder itself is not directly affected by sex and orgasm. What's more likely happening is, and this is the way it presents in a man. Okay, so we know bladder pain and pelvic pain can affect intimacy. In a man, the worst moment is the moment they ejaculate, and that pulsing as they're ejaculating, the muscle squeezing like that, that's their worst moment. For a woman, our flare usually begins a couple of hours after sex, like 6 hours, 4 hours, 6 hours, 8 hours after sex. That's when our flare kicks in. And that's when the female pelvic floor goes into a series of very gentle spasms that last for about a day, I think. That I think is related to our body helping sperm meet egg. But anyway, for that female flare after sex, it's a couple of hours after orgasm. And that is consistently being driven by pelvic floor muscles. And so what do you do for that? A muscle relaxant. So what's the rule? And I have a whole section on sex and intimacy over on our website that you can read. So there are a couple of rules that we do. That number one, when you have sex, enjoy it if you can. Please do. Sex is important. We need that intimacy in our life. It's important if you're not feeling well and intercourse is off the table. That's fine. You can do outercourse. If you need to say no, that's not today, I'm in too much pain, that's fine too. Just make sure you tell your partner, I'm not saying no to you. I love you dearly. I'm saying right now, my body is in too much pain to do this, but that doesn't mean that I can't pleasure you. Okay. Lots and lots of lube. Lots of lube. Dry skin on dry skin is bad. So I'm talking a half a tube of KY per sex act, please. And then if you're, after you have sex, and as soon as you can, but don't rush it, get up and pee. Let's try to just get anything that might have been pushed up into your urethra, into your bladder out by urinating. Then a heating pad, heat directly relaxes muscles. That's great. And then if you start feeling that flare, a skeletal muscle relaxant like baclofen or Flexeril. That's what we normally do for a sex-induced flare. Now, let me tell you a funny story, okay? So back in the days when we had an in-person support group, and of course there are no in-person IC support groups right now anywhere in the United States, at least I don't think there are. Nav says, what kind of lube? Well, I'm a KY girl. I like KY. I really personally like KY myself. Some people like slippery stuff. We're bringing in a lube from this company. I do believe that we're going to bring that into the IC Network store. I discussed more of that over on the IC Network website. I don't remember it off the top of my head. Okay, so I'm going to give you a funny sex story, okay? God's honest truth. Yes, water-based. So back with our big local group, Northern California group, we had about 300 patients in our group. And we were very, very assertive, and we did events, and we did an IC conference in our first 6 months. We chaired the pain conference, the state pain conference. I did that. So we were just a really gung-ho support group, right? I still try to be gung-ho, but in the early days, I was really gung-ho, like, let's bring the best experts here. So Evelyn, one of my co-leaders, said, let's do something on sex. And I'm like, great. And so she went to UC San Francisco, and she invited a very, very well-known professor therapist who specialized in sex disorders to come speak at our meeting. And it was, a lot of people came. And we were all just waiting, we met at a hospital. So we were all waiting for him and just kind of talking among ourselves. And in walked Santa Claus. I kid you not. Our sex therapist was the spitting image of Santa Claus. We're talking white curly hair, big white beard, big belly. And he walked in and introduced himself, and he's like, yeah, I'm Dr. Such and Such from UCSF. And we're like going, hey, it's really nice to meet you. And at the same time, we're going, oh my God, Santa Claus is going to teach us about sex. Okay. And he gave, just a fascinating, amazing talk. Like, one of the things we all have to understand about our relationships is that time matters. Things change with time. And so when you're very young, if you're in your late teens, early 20s, sex is very quick. Slam, bam, thank you, ma'am. It's like, get to the point of orgasm as quickly as you can. You're done pretty quickly. That's normally the way it goes for somebody who's a bit younger. And then as you go through your 20s and into your 30s, things kind of slow down. And now we're getting a little bit more into touching and loving and stroking, and a little bit less emphasis on big athletic sex, a little bit more on touching and cuddling and something like that. And then when you get in your 40s and your 50s, it becomes, and other health issues happen. Then we're dealing with a less intercourse, more touching and stroking, et cetera, et cetera. Okay. So it's a really good reminder that, and I think that this is something that I'm having to accept too, is that aging happens, things change, and it's okay if things change. The way we approach our relationships change. That's fine. The way we approach sex changes, and that's fine too. Okay. So anyway, give this absolutely fascinating, wonderful discussion on sex, and we're just like eating it up, going, oh my God, tell us more, tell us more. And then he said, I need to share with you the story of one of my clients. He and his wife see me because they have struggled with sexuality. And we're like, okay. He goes, here's the thing. I am so envious of their relationship. I've told them, you don't need to come see me. You guys are perfect. You are connected. You are together. You are pleasuring each other, but you have such a fulfilling relationship. He was just in awe of this couple. And he said, but there was something unusual about this couple. And we're like, what? He goes, well, there was an injury. And we're like, okay, what? He goes, well, he was in the war. And we're like, okay. He goes, well, a piece of shrapnel cut off his penis. He had no penis. And we were just like, what? And the question he asked us is, how can a man without a penis have a sex life that other men envy? And he was just honest. He said, I envy them. Like, I have never seen a couple so in love and so happy and so satisfied. So how can a man without a penis enjoy sex? And he said, because they were masters at outer course, not intercourse, outer course. And we're like, okay, what's that? And he said, you know that moment right before orgasm, and you're lucky to be there for a minute or two, where everything is like, oh, this is so great. Feels so good. And then orgasm happens and you're kind of done. The goal of outer course is to get your partner to that point and keep them there for as long as you can, 30 minutes, an hour. How do you do that? With touching, stroking, licking, whatever you need to do. And you know what? If orgasm happens, great. It's fine. And if it doesn't happen, you're not going to care because you're going to feel so good anyway. And really none of us in our group had really ever thought of that before, you know. I mean, I was raised in a Lutheran family and my mother didn't even talk to me about sex. I knew nothing about sex, even till I went to college, you know. So anyway, you know, he taught the basics of outer course. Well, everybody walked out. The couples that were at that meeting, and there were probably 10, 15 couples there. They walked out. It was hysterical watching them walk out because they were all like leaning at each other. They were blushing. They were talking to each other going, we're going to try that. We're going to try that, right? I had straight couples. I had gay couples. I had young couples. I had very old couples. They were all just like, we're going to try it. Okay. At the next meeting a month later, I am telling you right now, they came back glowing. And the couple that glowed the most was the couple in their 80s. Oh my God, they were adorable. And they just, you know, it's like, how you doing? Oh, we're doing, the last meeting was so great. And what this older couple said is, oh my God, why didn't somebody teach us this in our 20s? We would have had a completely different sex life. So a true story from IC Redwood Empire support group meeting. Now, let me give you another story, another real life story that happened in my group. And I really wish we had an in-person group. I mean, they're just so fun to do, and there's nothing better than actually meeting somebody. I had a couple, Chuck and Joe, who longtime members of my group. They both passed away now. They were in their 70s when they came to my group. Okay, and Joe had the IC. Chuck was this wonderful, supportive husband who drove her everywhere. And we had a Christmas party. And they came in spitting fire. I had never seen them so angry at each other. They were furious. And Joanne was really, really angry. She was spitting fire. She was so angry. You could tell they'd been fighting in the car. And literally couldn't do the meeting. I mean, we just had to kind of stop what we were going to do. And it's like, okay, Joe, what's going on? And she burst into tears and she said, he doesn't love me anymore. He won't even touch me. And she just sobs uncontrollably. I mean, she's just like, her heart is broken. Now, I met them several times. I've even built their business website for them years ago. Chuck is a teddy bear of a guy. He saw his wife crying and he was broken. And he said to me, he said, she won't let me touch her. Whenever I try, she pushes me away. Because she was in so much pain, she didn't want to be touched. And then Joanne looked up, tears going on her face, going, he should know when I need a hug. And he's like, how? The last thing I want to do is hurt you. And every time I come close, you push me away because you think I'm going to hurt you. I don't know when you need a hug. You have to tell me. And she, and she is worked herself up into, this other level of anger. And she's like, you should know when I need a hug. And I stepped in as a group leader. And I said, now, wait a second. Just hold on one tight. He cannot read your mind. He can't do it. And the hard reality here is you are a severe IC patient and you have been in severe pain for a long time and you have pushed him away, right? And she's like, yes, I have. He loves you so much. He doesn't want to hurt you. He's afraid to touch you now because he never knows how you feel. And that made her, she's like, oh. And I said, you got to tell him. If you need a hug, grab your hug. Walk up to him. Put your arms around him. Give him a hug. One of the things that I say to patients is you got to have a safe word. One of the flaws that sometimes I see patients make, especially if you're at home and your partner is at work, is let's just say you're having a horrible day. Like, man, you are so annoyed. You're in a horrible flare. You're peeing all the time. You can't get through the doctor. Your stress level is just up, 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 up. You are bottling it in inside. You have not talking to anybody. You're just waiting for your spouse to get home. And when your spouse gets home, bam, they hear about it. Horrible day. Doctors ignored me. And that's a horrible thing to do to your partner because they can't say what you need them to say because they have never lived with the pain that you are living with. And this is why having some IC buddies, and I will be your buddy. I am IC buddies with thousands of patients. If you need to vent, don't vent to your partner, vent to me. Go onto an online support group, vent in the support group. Get it all out. Get your stress out, get your anger out, get your frustration out, get it all out so that when your partner comes home, you can greet them with love. How was your day, hon? Relationships are challenging here, my friends. Relationships are challenging. I am in a relationship now. Well, I think it's a relationship. I'm not sure. I met a new guy last summer, and he's lovely. He's lovely. He lives in another county, so he's the brother of a neighbor. So I don't get to see him that often, but he has cancer. I had cancer, and that's how we connected as we were talking about our cancer struggles. And I just said to him one day, I just said, listen, if you just need to get away, come on up to my house. We'll play games. And oh my God, we have the best time playing games and putting music on. We just put on 70s and 80s music because we're in our 60s. We're the same age. And I've never laughed so much in my life. And I came to realize that that's what I've been missing in the last 20 years of caring for my parents is my laugh had gone away. And it's so nice to have moments of just pure and utter fun and laughter. Like we play the game of life. Oh my God. Playing the game of life in your 60s is hysterical because it is remarkably accurate. we played a lot of different games. I have not been in a relationship in 15 years because I was just consumed with caring for my parents. I just didn't have time. And now that I'm in a relationship again, but I as I said to him, I said, I am not a catch. Like the very first thing I said is, you have to understand that I am fundamentally broken. I have no breasts and I've got half a vagina. I am not a catch. You know, I am not a catch. And, you know, he kind of looked at me and he's like, Jill, I don't care that you don't have breasts. I don't care that you only have half a vagina. I just like you. And, but I am having a lot of trouble allowing myself to be open to that. And that's a pain response. But see, that's a pain response. As I have said for the last 2 years, I have been a bear in a cave. My pain level, well, my grief was so severe, and then to go through 2 surgeries, and then to have complications, and to have horrific post-op pain. I had just been hiding in a cave, my home, for 18 months. And it is very, very hard to let anybody touch me. The pain response. So I understand Joanne a lot more now. You know, it's interesting how we react to things like that. And I know he's very confused by me. And my only answer is, I'm not out of my cave yet. I just have to heal a little bit more before I can commit to a relationship. If that, and I'm sure that makes sense, right? Life is just so weird. Nav says, this condition affects the nervous system terribly. When I have a flare, I get so much anxiety and I feel depressed and even mad. Yeah, me too. Me too. And I've had a lot more, like I was the family member everybody could count on, up until May of 23. Like, if anybody needed anything, I would get it to them. If my life stopped as I was caring for my parents, and then they died together, you know, a couple of days apart. And it all came crashing down. I realized that I had been running exhausted for a couple of years. I did not understand the toll of caregiving, and that I had nothing in my tank. I had nothing in my tank. And I can remember they died in May, and my birthday was in July. I just shut it down. I'm like, I don't want a birthday. Just everybody leave me alone. And I just cried every day for about a year. You know, I did. And then the breast cancer happened. You know, just when things were getting better and I'm now coming up on another birthday, now I get to have a birthday. Nope. I had a double mastectomy a couple of days before my birthday. So I spent my birthday in 24 in horrific pain. You know? So that depression and the anxiety is a normal response to trauma, my friend. What's not normal is living in it. And I went and did therapy. And I still have moments when it's really helpful for me to talk to somebody, as you can tell by me. I mean, at least I really understand what's happening. But, you know, it's okay to be anxious. If you're dealing with a pain condition like I see, it's okay to be frustrated and angry. If you're not getting the care you need, if you're not responding to therapy, that's perfectly normal. But at the same time, you know, it's a slippery slope. And you don't have to do this all alone. You don't have to recreate the wheel. There is nothing more vital than having somebody to talk to who's been through it, who can give you tips. There are pain psychologists out there who are fabulous. Yeah, and even talking to a priest or a minister might be helpful, but it's not going to be as helpful as somebody who can help you navigate that journey of trying to recover from an illness and trauma, right? Because we don't want you living in that state of depression and anxiety, because that just amplifies your pain. When you're anxious, you're in fight or flight. Fight or flight, your brain amplifies and intensifies your pain. We got to get you out of that, which means we got to get you out of your cave, which means we got to get you out into the sunshine. What's the first thing I did this morning? I went over to the lake and walked around the lake. I always feel better when I'm outside in the sunshine. My windows are open. The window is open. I do not live in a dark house. I crave the sunshine. And it's just so important that we take care of our mental health too. And so a year ago, a little bit more than a year ago, I started becoming really anxious again. And I developed a fear of taking my blood pressure because I was taking my dad's blood pressure as he was dying. And I still don't like taking it even now, but I was talking to my doctor about it. It's like completely irrational. It makes no sense to me. Well, no, it does make sense to me. Totally trauma driven. And she said, you know what? You really need to go talk to somebody. And I went, you better believe it. I know I need to talk to somebody. And I ended up going through EMDR trauma therapy that was life-changing. And EMDR therapy is not necessarily talk therapy. EMDR therapy is about teaching your brain to get out of fight or flight and out of trauma. And it's stunningly helpful. We did it over Zoom. So easy to do. So now what I would just say to you is that nobody wants you to be in that space for a long period of time. It's not going to be good for your long-term health. It's not going to be good for your pain levels. This is where we as patients have to dig down deep and admit, you know what? I really suck at anxiety management. I probably might benefit from some new skills. I have a really good video on an anxiety class that I took years ago that completely changed my life. I do not normally live in anxiety. I did after breast cancer, but for a good 25 years, my anxiety level was tiny. And it was all from a very, very simple class that I took that gave me a new set of skills. So if you can, go over to our YouTube channel, which is youtube.com/ICNJill. And there's hundreds of videos over there. You'll just have to dig until you find the anxiety one. Or you can go to our video page on the IC Network website and you can find it there. Julia says, great story. So thankful for you. Thank you. You're welcome. Christy said, that's awesome, Jill. You so deserve it. You help us out so much. I try. I definitely try. Another really good speaker that we had was a speaker in mindfulness. Now, you know, the wonderful Dr. Klein, who I adore to this day, my very first appointment when I saw him, before I was even diagnosed with interstitial cystitis, he suggested, this was in 1992, that I go over to the psych department and learn about mindfulness. And I was so offended. And I just said, listen, I'm peeing all night long. That is not in my mind. That is in my brain. I mean, that is in my bladder. I am not interested in going to talk to somebody in the psych department about my IC. I want you to look at my bladder and help me understand what's wrong with my bladder. He's like, okay. Well, he was right in a way, because now that we're phenotyping my phenotype, and again, he did cystoscopies, perfectly normal bladder. There's nothing ever wrong with my bladder, despite the fact that I was up all night crying in severe pain and peeing every 15 minutes at times. That I am, in fact, a pelvic floor patient, but we didn't know that back then. But I'm also a widespread pain patient. I have that nerve sensitivity, so I have a history of IC, IBS, vulvodynia, TMJ. I still have TMJ today. And it's pretty aggressive TMJ. I had migraines briefly. That's part of the widespread pain phenotype. And that actually is driven by the central nervous system. That is a systemic condition. And in fact, if you look at our guidelines and you look at the phenotyping, what we clearly see now is that patients with systemic symptoms with a normal bladder capacity do not normally respond to bladder therapy. Bladder therapies are for patients who have bladder-centric pain with a smaller bladder capacity or Hunner's lesion. So let me say this again. If you have a normal bladder and you have multiple sources of pain beyond your bladder, that puts you into the systemic group. That means that you're probably in the widespread pain group. That means that your central nervous system is driving these symptoms as compared to the bladder wall. That's about 40% of IC patients. About 5% of IC patients have Hunner's lesions. That is absolutely bladder-centric. They don't have the other pain conditions. They just got a screaming bladder. So bladder-centric, widespread pain. And interestingly, the only patients that respond successfully to bladder removal are the patients who are bladder-centric. If you've got any pain outside of your bladder removal is not going to do a darn thing. And that's a very rarely done. Okay, so anyway, Dr. Klein very clearly saw that I was a widespread pain patient. I didn't understand it at the time. I had no freaking clue why. Despite my master's degree in psychology, I didn't understand at all. So then phenotyping comes out. Clearly, I'm in the widespread pain group. Clearly, I'm in the pelvic floor pain group. And as more and more research emerged in the widespread pain group, that anxiety is incredibly ingrained in patients with widespread pain, that we live with anxiety disorder, often extreme anxiety disorder. Why? Because widespread pain is driven by trauma. It can be driven by physical trauma, or it can be driven by emotional trauma and abuse and bullying, things like that. Okay, so I'm making a long arc to this speaker. So anyway, we have a speaker come to our meeting, a mindfulness speaker. And she taught us something that I think was really, really important about flares. She said, when you have a flare, it's scary, right? And we're like, yes, it hurts badly. And when you have a flare, you have a very strong emotional reaction to that flare. Specifically, most of you are going to worry, oh my God, what if it never goes away? Man, she knew us, and we were like, yeah, exactly. Exactly. If you've got a severe flare, that emotional reaction to that pain is profound. And there's worry. It's like, oh my God, maybe it'll never go away. But then the flare passes. A couple of days later, week later, month later, whatever. The flare, that's the nature of flares. They come up and down and up and down. The flare passes. Everything calms down, and then 2 months later, bam, another flare. Another, oh my God, what if it's never going to go away? And then, especially if it's a diet-induced flare, bladder calms down, it goes away. She said, we call that the runaway train of emotion. And she asked us, do you really have to get that emotional over a flare? every single time. You know the flare is going to get better. So do you have to live in this space of assuming that the sky is falling and life is over and yada, 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 because this is a flare? Or can we just go, it's just a flare, and just step off the runaway train of getting all upset and anxious over it? And I'm not describing that as well as she did. But that taught me something really important. And that is that I never get upset about flares. Ever since that class. It's like, it's just a flare. That's it. I don't need to get upset about this. And usually when you have flares, you can figure out what's caused that flare. Oh, yeah, man, you know what? I had a soda. Of course I'm going to flare. I don't need to get worked up about this flare. When you take your power back, when you refuse to give it away, when you I'm not saying this well. I'm sorry. I wish I could remember exactly what she said. Basically what she said is that pain triggers an emotional reaction. The emotional reaction can make it much worse than it really is. Because when you're anxious, when you're depressed, your brain intensifies pain. That's part of the fight or flight response. And she said an important way to deal with this is to learn to step away from that emotional response. It's like, it's a flare. Okay, yes, I flare every time I ovulate. Not a big deal. It's a flare a couple of days before my period. Do I gotta allow myself to get upset every month? It's just a flare. I know it's going to go away. Now, of course, we have to learn from that flare. I mean, we have a lot of control over our flares. I have a great flare guide if you're struggling with flares, to teach you what causes flares and how to respond to flares and how to treat the flares that when they're happening. Where is it? Right? So you can get the flare guide. It talks about bladder wall flares, pelvic floor flares, urethral flares, rectal flares, sex flares, vulvodynia flares, etc. And this is filled with everything we know about flares, what your phenotype determines your flare risk, and what are the symptoms of each different types of flares, how to differentiate between a bladder wall flare and a pelvic floor flare. Most importantly, how to rescue yourself out of that flare. So, as Julia says, getting upset makes the pain worse. It does. It really, really does. It does make it much, much worse. The other thing that I think is so interesting, and this is something I learned when I was younger, and I talked about this a couple weeks ago. Let's say you notice something that doesn't on your body that worries you. It's like, what is that? Like, what is that spot, or what is that pain? And I remember I had skin cancer on my shoulder. Looked like a little volcano. I thought it was a mole. And I'm just like, it's a mole, no biggie. And normally I would just watch it for months and months and months and months. And it's like, is it getting bigger? Is it getting worse? Yada, yada, yada. And then I'd be worrying that whole time. Well, what if it's cancer? What if it's cancer? Oh my God, maybe it's cancer. Maybe it's really bad cancer. And I would torture myself with a wide variety of things like that. And then you go to the doctor, and the doctor looks at it and goes, no, it's not cancer. You're fine. You walk out, you walk into the doctor's office thinking the sky is falling. It's going to be really bad news. You feel awful. You feel horrible. And then the doctor goes, worry about it. You're fine. And all of a sudden, all that weight of stress and anxiety lifts and you walk out bouncing. I'm fine. I'm fine. And I realized that I let anxiety back when I was younger cause a lot of unnecessary stress. And now if there's something that I'm worried about, I just go to the doctor. I don't wait. I'll take a picture of it, email my doctor. I just refuse to allow myself to live in the worry zone like I used to. And that's just really helpful if provided you have healthcare. By the way, my best friend who was supposed to get on a plane tomorrow just got diagnosed with the flu. The flu is still big here in California, my friends, so protect yourselves. It's a wicked year this year. All right, let me check over here. Oh, you guys, I'm sorry, YouTube. Hold on one sec. Jennifer said, ultrasound, internal, external, CT down. Ultrasounds are so painful. Could barely hold any water in my bladder. Thank you so much, Jill. You've been very helpful. Weenie said, thank you for being so generous with your time and knowledge for a not uncommon group of conditions. There are not many out there offering relief. Yep. Thank you, hun. While the boss is away, says, hello, coming in late and glad to be here. I'm glad you're here. I am glad you're here now. Oh, see, ow. That's a little challenging. Okay. I am here as long as you have questions for me. Now, hold on one sec. Actually, let me go get something on my kitchen table. I'll be right back. So this is the draft of our winter magazine. And I think that there are a couple of things in here I wanted to talk to you about. So hold on one second. My editorial is on phenotyping. Let's see here. So at our meeting last week, I went over all the treatment discussion from the global consensus meeting. Again, for people who came in late, there was a big meeting last year with 60 of the best IC clinicians and researchers who came together to come up with kind of new strategies on clinical care and research. And their number one focus is, listen, we're not just going to give everybody bladder treatments because bladder treatments don't work for most people. That treatment has to be customized based upon your phenotype, and your phenotype determines which treatment is going to be the most successful for you. So if you have tight pelvic floor muscles, you're going to physical therapy. If you've got widespread pain, we need to do systemic medications and other therapies that are going to calm that sensitive injured nervous system. If you've got Hunner's lesions, we're going to do Hunner's lesion treatment. If you've got bladder wall driven symptoms, then they're going to do other bladder-centric treatment. But again, that's way too broad, and I don't think that's particularly helpful. One of the things that they talked about is immunotherapy, because we do have some research in which they believe that some patients with Hunner's lesions have an autoimmune disease. And so they're doing immunotherapy now to try to calm that response. And in that is going to be cyclosporin. Cyclosporin is a medication that is often used with transplants. It's all about preventing the body's rejection of a transplanted organ. It suppresses the immune system. And for patients who have recurring Hunner's lesions that are not responding to therapy, cyclosporin has been a bit of a miracle drug. Many, many patients have used it now. I've got good friends who have used it and are using it. The challenge with cyclosporin is that it has a lot of potentially serious side effects, like raising your blood pressure and having a blood pressure crisis. And so cyclosporin has to be monitored very, very carefully. So is there a phenotype that focuses on immunity? I think there should be. The more phenotypes we have, the better. Max said, can endometriosis mimic IC? It's been 3 years. My urologist referred me to a gynecologist who's saying endo and trying meds, but I'm not sure if it's just a Hail Mary. Needs to be ruled out, girl. Listen, you are an anatomical mystery to be solved. Endometriosis is well known to cause widespread pain, a phenotype for IC. You can have endometriosis attached to your bladder. That endometriosis can burrow into your bladder. That endometriosis can attach to your rectum. It can attach to your bowel. So it is very important to get checked out for endo. I had a laparotomy for me. Hey, listen, I didn't believe it when they told me they had IC. I thought I was dying of cancer, to be quite honest. And I demanded exploratory surgery. I just said, I don't believe you. I need you to open me up. I think I'm dying. I mean, my pain level was so severe. I believe that I'm dying. You've missed something. And I remember my gynecologist said, really? And I went, oh, hell yeah, open me up. I want that laparoscopy. And I had it in September 1993. And I'm not saying everybody has to have a laparotomy, but we have to open our eyes here and understand that other conditions can impact the bladder and cause some of these symptoms. And endometriosis is one of them. And they didn't find endometriosis for me, but they find endometriosis in a lot of IC patients. And if you have it, then we want to get it treated correctly. So I say, hell yeah. And then the other thing that I would be checking for is pelvic floor dysfunction. And what did we start this meeting off with? This meeting, we were talking about pelvic congestion syndrome. That you can have a compressed blood vessel, or you can have a varicose vein in your pelvis that causes pelvic congestion syndrome that has been linked to vulvodynia, IC, IBS, migraines, cognitive decline, anxiety, depression. And so if you watch this meeting when it's over, I go through this long case study of this woman who had to drop out of grad school. I mean, she had horrific symptoms throughout her entire body. And in the end, it all went down to the fact that she had a compromised blood supply in her pelvis that was affecting her brain. And once they treated that, her pelvic pain went away, her cognitive decline went away, and she is better. And she had seen 60 doctors. She had migraines every day. That's pretty much gone now. Once they restored blood supply down in her pelvis, and they got rid of the blockages, her life came back. So that's something else that they want to look for. Listen, if you feel like you're carrying a bowling ball around in your pelvis, if you feel an overwhelming sense of pressure, that is the classic symptom of pelvic congestion syndrome. They would do a CAT scan or an MRI to make sure you don't have this. An estimated 30%. Now, I'm writing an article on this, but it's either 30% of IC patients or 30% of women have pelvic congestion syndrome. I just couldn't find it at the start of the meeting to clarify that. But pelvic congestion syndrome is often missed in women and men with pelvic pain. So bladder therapies are not going to do a damn thing for these patients. We got to restore blood supply. That's our goal, is to restore blood flow. So Debbie says here, I have a bowling ball in my vagina. Okay, so Debbie, two scenarios there. If it feels like a bowling ball, and if that bowling ball gets worse as the day goes on, classic symptom of pelvic congestion syndrome. But the other thing we would want to look for in you in that sensation is, do you have a prolapse? If you feel something large and hard at the entrance to your vagina, that actually is going to be a prolapse, and that needs to be fixed too. Debbie says, funny, I just read up on that today. Yeah, we've talked about it a lot over the years. But it's really resonating now. And we had, again, this great case study of this woman who had to drop out of grad school. She had just body-wide symptoms from terrible migraines every day to pelvic pain. She had terrible constipation. She had vulvodynia. She had so many different things going on. But what the doctors noticed was her cognitive decline. Like, she wasn't finishing sentences. She was getting slow. There were just a number of cognitive symptoms diagnosed with attention deficit. And she wasn't remembering things. Her memory was very, very poor. And so when she came to this new doctor who wrote the case study, so, and I read all of that. So they document all that. And then they did the exam. And while things appeared normal, her kidney function was normal. When they looked at her vulva, they found varicose veins, like visible varicose veins on her vulva. And that led them to go, maybe we've got a problem with blood supply and circulation. And they did a magnetic resonance venous exam where they found that her left iliac vein was 50%, more than 50% compromised. So they repaired it with a stent. And 30 days later, her cognition was better. Her migraines were better. And she had a couple of little setbacks. She had a lot of pain with sex. They were able to fix that with some shots into her vaginal wall. And she was doing well. And then a year after that, some of the symptoms started coming back. Some of the memory issues started coming back. And they thought, it sounds like we're seeing congestion again. And they found it again in her right iliac vein. They fixed that. And 30 months after they fixed that, she's back. Her IQ improved. She had her anxiety and depression was gone. Her cognition was there. Her memory was back. They did all the neuropsychiatric testing, and flying colors. Her pelvic pain was better. Her pain with intimacy was better. Everything improved once they got her blood supply restored. And the power of this case study, to me, it's all about, the thing is that there are men and women right now who are very similar to that. They've got so many things going wrong with them, and nothing makes sense. Nothing makes sense. And they go to doctor to doctor to doctor. Please help me. I'm horribly constipated. Or please help me. My memory's poor. Or please help me. I've got this and this and this. And nobody made that connection. And I can damn well guarantee that a huge number of the people she saw thought it was all in her head. I mean, think about how we're labeled, how patients are labeled who have this. We all get minimized, pushed away. Oh, what's wrong with Jill now? I mean, that's how I felt in my 20s and 30s. And they found it. And it wasn't all in her head. It was all in her damn pelvis. And it related to blood supply. Her brain was not getting the proper blood supply because key vessels were blocked. So you are an anatomical mystery to be solved. And for everybody out there who is just like you're spinning in a circle and you just do not know what the hell is going on, please don't give up. Don't assume you're going to live with this for the rest of your life. Man, it begins with you. It begins with your knowledge. It begins with you being willing to walk into a doctor's office. Don't burst into tears. That doesn't help. You walk in with a bunch of questions. Okay, doc, I'm here because I want to know, is my bladder healthy? You know, have you looked at my bladder? Why is my bladder screaming? I mean, okay, I'm not saying that right. When you go into the doctor, you want to know the health of your bladder. You want to know the health of your muscles. You want to know the health of your nervous system. You want to know the health of your skin. Do not just walk in and say, I've got IC. Can you give me something? That's not get you where you need to go, because they're happy to give you a pill. They'll put you on an antidepressant and you might feel a little bit better, but it's not going to fix the underlying problem. You got to dive into the anatomy a little bit more. I had a lady that I was working with on Thursday or Friday, and I in a very gentle way, really chewed her out because she kept saying, my husband does that. My husband does that. My husband does that. And I went, no, wait a second. This is your body. Your husband shouldn't be doing that. You need to do that. What treatments do you have? I don't know. My husband knows that. No. I need you knowledgeable, invested in your health, and willing to fight for yourself in a very proactive way. And we got to be humble. We got to admit, man, you know what? I suck at anxiety management. Yes, I need to take a class. That's fine. I am happy to take a class in anxiety management, but that doesn't explain why I'm constipated all the time, or why my right knee starts to give out, which my right knee does start to give out every now and then. All right. Debbie says, it's awful. Just went for an MRI and found out I have disc bulges and a tear with a cyst. I swear it's all the reason for this IC. I often feel they gave up on me. Well, don't let them give up now. Now you know what you've got. You got disc bulges. Now your question is, what are we going to do for that? Are we going to strengthen my muscles to support my spine a little bit more? Or are the bulges so severe that we're going to need surgery? Larissa said, thank you so much. I see my Eurogyne tomorrow, and thanks for all the new things you have brought to us. You're welcome, Larissa. Debbie said, I have a new Eurogyne visit also. So informative. So here's the other thing that we're really struggling with right now, and that is that our experts in IC are retiring, and we do not have a new generation of IC experts to pick up where they've left off. We're seeing doctors who are retiring who do not have transition plans for their patients. They don't. So some patients who have seen some of these big IC experts, one up in Canada, for example, her doctor retired. She called and they said, well, we don't treat IC anymore. And she's like, I've been coming here for 15 years. What do I do? They went, you got to find somebody else. So understand that there is a bias about IC. And I don't think it's helpful for you to go in and say you're an IC patient. I don't think that that's helpful. If anything, that's going to close more doors. I think it's important that you walk in and say, I'm a pelvic pain patient. I'm trying to figure out why I have this pain. I'm looking for somebody to look at my vagina to tell me what the health of my vagina is. I'm looking for somebody to help me with my muscles. If my muscles are contributing to my pelvic pain, I'm looking for somebody to help me figure out if I've got an infection. So saying IC is closing a lot of doors right now, and we're seeing that around the world. So I don't think it's helpful to say I see right now. I think it's helpful to say that I'm a pelvic pain patient. And even then, some doctors are going to be uncomfortable with that, but I think you'll see more. And then understand too, ooh, John's going to see a new urologist on Wednesday. Good luck, dude. So, John, you're like the perfect example of saying, I am an anatomical mystery to be solved. I've been diagnosed with this and this and this, but here's the hard reality. Those treatments never worked for me. And I'm looking for, now I have to think about this for you, my friend. I don't know, would I start that way? I think it's very important that you walk in and say, my pain is at this location. I need you to help me understand why my pain is happening right here. That's what I would do. And again, not even say I see. Debbie says, I don't believe the new generation are as knowledgeable. Yeah, it's tricky. It's tricky. I was just, I just wrote a letter to an IC expert in the United States here. In fact, I think she wrote me back. Let me see if I can find it. I suggested that we meet because we have got to create a system that will identify, recognize, and nurture those young doctors who will work with pelvic pain. We're in a really weird place. And so, again, you shouldn't be assuming nobody will care for me. You got to be more clever. Like, you got to read our website, understand phenotyping. That's going to give you a lot of clues. You're always welcome to call me. And listen, if you've got tight pelvic floor muscles, you can go to a physical therapist is probably going to be your primary care point. If you've got Hunner's lesions, then a urologist is going to be your thing. If you've got estrogen atrophy, then you're going to be under the care of a gynecologist. So we don't even really, I think most IC patients probably don't even need to be under the care of a urologist right now. I haven't seen a urologist in 25 years. I go to my gynecologist, and I haven't even seen my gynecologist in 7 years. My point of care is my physiatrist and my pelvic floor, because my fundamental problem is there. Debbie says, I'm going to correct my new inpatient form and omit IC. It's not a bad idea. And if you're of a certain age, you can just say estrogen atrophy. Debbie says, how to contact you? You can go to our website, our phone number. There's an 800 number right at the top of our website. It's on this back here, which my head blocks. 800-928-7496. What do we name the condition for the purpose of SSDI? Well, Social Security does have an interstitial cystitis ruling. It's not an automatic approval. It's more a ruling to help Social Security staff understand the nature of the potential disability of somebody who's living with persistent bladder pain and bladder symptoms. Your success in getting SSDI is really going to be about documenting the totality of your issues, and having a doctor that will back up what you're saying. So the fact that if you had to medically retire, if you can't sit at your desk to work for more than 15 minutes at a time, if you can't drive to work because it's too painful to be in the car, it's all about how does your illness interfere with your ability, your illness or your injury interfere with your ability to perform the essential functions of your job. So really what's really important for Social Security is not just to say you have IC, but to provide an in-depth review of what you're struggling with. So if you've got persistent constipation and are unable to have a bowel movement comfortably or easily, if you have pain with sitting, if you know what I mean. I have a whole Social Security section on our website that you can go through if you want. Your case is interesting, John. We should talk. I worked for Social Security for a year. I was a black lung specialist with Social Security for a year before I went back to grad school. So I do kind of know their system, although it has changed, but I do know their system fairly well. Debbie, with hers with sleep deprivation. Yeah, sleep deprivation is important, because if you're unable to sleep and you're doing a job like operating a forklift, yeah, you can't do that if you're sleep deprived. If you need to, so there are lots of different ways of showing how this condition can become so severe that you are unable to work. All right. So hold on a second. We do have 3 new experimental therapies that are showing some promise. One is called certolizumab. I don't know what its method of action is. Another one is tanezumab, an anti-nerve growth factor agent, and another one is gefapixant. I don't know who the hell comes up with these names for these meds. They're so weird. But what we're seeing a lot of now is a lot of low-intensity shockwave therapy. And I know I was exchanging email with Ken Peters, who's one of the top IC doctors, a master diagnostician up in Michigan, who is using a low-intensity shockwave therapy very successfully, believes that it's helping quite a few patients. Okay, what else do I have in here? We have our essentials for your IC Flare toolkit. But hold on a sec. What else did I have in here? Overcoming the fear of the IC diet, how to eat with confidence. Prolapse has been linked now firmly to IC symptoms. So we have an article on that. We have an article on Lyme disease, Borrelia, which is the bug in Lyme disease, has been found in the bladder. It's very common for people with chronic Lyme disease to have urinary symptoms. Oh, I know. Oh, this was so interesting. Here's the last thing I'll talk about for today. Again, I'm happy to take any questions you have. But so I had a patient call this week who had been struggling with bladder infections. And they found that she had a very rare, unusual bladder infection that is commonly referred to as pink mold. So pink mold appears in showers as a slimy pink residue. It thrives in warm, moist environments, feeding on soap scum and mineral deposits. It's not actually mold. It's actually a bacteria called Serratia maricens. And you know what? She had that infection in her bladder. And they were all stunned. And it turned out that she found, I don't remember how much, but they actually, I think it was a lot, that they had found this pink mold, this serratia, in her bathroom. because she was describing to me how they had to clean it. It was very hard to kill it and clean it. And so let's see. While generally harmless to healthy individuals, it can cause infections in vulnerable people and should be cleaned with bleach or vinegar, followed by preventative drying of surfaces. I had never heard of pink mold. And you know what? I found pink mold in a bird bath. And I'm like, and I brought the bird bath in my house to clean it. And then I sprayed everything really bad with, really strongly with Lysol. So hold on a sec. That was fascinating to me. We also have another patient whose IC symptoms were being caused by black mold in her home. I mean, legit black mold in her home. And so everybody in her home was sick. She was sick. Her IC was off the charts. It was really, really bad. But her husband had stuff going on. Her children had stuff going on. And finally, what they found is that the water heater was leaking into the pad underneath her carpet. And when they pulled the carpet up, the entire pad throughout the house was filled with massive amounts of black mold. And urinary symptoms can be caused by real black mold. So they had to immediately move out of the house. And it took about 6 months, but everybody got better. Her IC symptoms disappeared. Everybody's illnesses got better. And so, you are an anatomical mystery to be solved, and we just have to rule a lot of stuff in and out here. Peggy said, I've been coming to your support group meetings for almost 2 years. I don't know where I'd be if I didn't see you on Facebook. We ruled out many things. I am on Prepper and vaginal cream. BID. Excellent. Let's see here. Hold on. Sister Steele, you went to see a great physical therapist. I'm also taking some pain meds when needed, Flexeril for muscle spasm, and lactoferrin. It took me this long to find out what helps me, but it was well worth it. Thank you so much for your kindness and support. You're welcome, Peggy. Peggy, you just made my day. Thank you, hon. All right. Max on YouTube says, every woman in my maternal line has symptomatic confirmed endometriosis, but this all came on after a UTI, so I'm confused, but thank you. I'll keep going along with the gynecologist. So here's the thing about endometriosis, Max. There's a fabulous nonprofit called the Endometriosis Association. I would encourage you to join them. They had a very big breakthrough early back in the 80s to try to understand what was driving endo, because prior to World War II, there's very, very little endometriosis in the world, very, very little. And then it just exploded. And now there are many millions of women struggling with endometriosis in the United States and around the world. The question is why? What's driving it? So back in the 80s, when the Endometriosis Association was getting started, there was a little tiny article in this really a research journal, a chemical safety research journal, that referenced endometriosis in connection with dioxin. So dioxin is considered the most harmful man-made chemical ever. And dioxin becomes very environmental. It happens when you burn plastic. So when you burn plastic, dioxin is produced, goes up the chimney. This is why you never burn plastic in your fireplace, and it settles in the environment. And so it settles in the grass. Well, then you have cows eating the grass. So now the cows have high levels of dioxin, which then accumulates in the milk. And then the milk goes to the grocery store, and then you drink the milk, and now you've got dioxin in your body. Okay. So the industry, the plastic industry, was trying to prove that dioxin was safe. So they were doing monkey studies. So they were giving a large group of monkeys, doses of dioxin. And, so some had little and, just increasing doses. And a monkey died. And when they did the necropsy, the monkey was filled with endometriosis, filled. And the researchers published the paper. And they said that they believe that dioxin, which is an estrogen mimicker, contributed to the development of endometriosis in this monkey, eventually killing this monkey. Well, the volunteers of the Endometriosis Association found this article, and then they went, I think, to the National Institutes of Health, because I think it was an NIH study. I don't remember the details. And they had shut down the study, and they were going to either kill the monkeys or sell the monkeys off to other researchers, which is why I gave up working in drug development. The animal research is disgusting. Disgusting. The stories I could tell you. Ugh. They were able to petition to have the researchers do laparoscopies on all the monkeys in the study. And I don't know what happened to the monkeys after the study. I genuinely don't. But what they found is that every single monkey exposed to dioxin had endometriosis, and the more dioxin they were exposed to, the more the endometriosis grew. So we had a direct cause and effect. This man-made chemical caused the growth of endometriosis. Then, I don't know if it was them or it was another study, they were able to show that the dioxin exposure didn't necessarily happen to the patient. It could go back a couple of generations. So it could have been a grandmother who was exposed to dioxin, who then passed along to their daughter, who then passed along to their daughter. Now, I know that I wrote about this. I would have to dig to find that reference. There's an article in our magazine, an interview, I think her name is Mary Jo, where we talked about this. And so the fact that you have endometriosis confirmed multiple generations supports that. That it and think about it. Think about when plastics were developed. Plastics became very big, in the 20th century, in the mid 20th century, World War II, before World War II, World War II, especially after World War II. And so plastics were huge, and plastics are ginormous now. But the devastating effects of plastic waste and how do you dispose of plastic is a whole nother story. So our environment now is filled with plastic waste and filled with dioxin. And every couple of years, there's a new chemical that's added to that list, is known to contribute to endometrial growth. And so what the Endometriosis Association says is it's really, really, really important that you clean up your home, get rid of all the toxic chemicals in your home. Like no scented candles from China, no Glade plugins, none of that stuff. No oven cleaner. You got to use plant-based stuff. Because one of the flaws here in the United States, as compared to Europe, for example, in Europe, manufacturers are required to prove that their products are safe before they can come onto the market. In the United States, we don't require that. And then you have to throw in all the new chemicals that are introduced through products from China, where we don't know what the hell those are. Our environment and our homes have been massively contaminated, in my opinion. And so I just think getting back to nature, trying to use less polyester, more cotton, more natural ingredients, less chemical ingredients, more organic foods than foods that have been treated with pesticides is going to be the secret to us getting better. in the long run. Listen, speaking as a chemist, I wouldn't trust a chemical company if my life depended on it. I wouldn't trust a pharmaceutical company if my life depended on it at this point in time. They're in it for the money, not necessarily for the safety. Not to be cynical, but I am somewhat cynical now. All right, guys. Well, listen, I think, so we've been live now for, I think, almost 3 hours. If anybody wants to go into Zoom, we can go into Zoom. But let me just do a last call for questions. Last call for questions. And understand, guys, boy, if there's one thing I've learned now that I'm getting so much older is for every question I have an answer to, there's another 100 questions that we don't have an answer to. And I find myself when I'm reading these journals now, I'm really reminded of how little I know in the long run. You know, I mean, there's just so much that we don't know, and we just all have to be a little bit more on the humble side. I want to try to be humble. I'm sure that there have been a lot more breakthroughs with endometriosis. I've just been dealing with my stuff for a couple of years, and I'm pretty disconnected, but I'm getting back into being connected again, if that makes sense. All right, my friends. Now, is the Super Bowl next week? When is the Super Bowl? It's next Sunday at 3:30 p.m. Okay. Okay. So, I should be doing a meeting. Knock on wood. Knock on wood. You should see me here next week. In the meantime, I really hope that y'all have a great week. And if you need any help with your IC, please don't hesitate to give me a phone call. Again, I'm not a doctor. I'm an educator. My job is to educate you, inform you, maybe open up some new doors and send you back to the doctor with a new set of questions. My phones are first come, first serve every day. I encourage you to be at the squeaky wheel if you don't hear back from me. Listen, if you call and you get my message, or more importantly, you get a text back saying, I can't talk right now, leave your name and number. I will call you back when I can. But some days I'm on the phone all day. Other days I don't get very many phone calls, and I get to write to my heart's content, which is great too. So anyway, just be the squeaky wheel. It's okay to try over and over until you connect to me, okay? All right, my friends. I'll say goodbye to YouTube first. See you later, YouTube. Be well.